And I think I'll request him to kindly start the proceeding of his presentation. Dr. Rajeev Gupta, sir.
Thank you very much for the kind words, and just without wasting time, let me start the presentation. What I'm going to talk today is a management of resistant hypertension, and Gurpreet, a great friend of mine, has already set the stage that we need to learn a lot about resistant hypertension. Now, these are the latest definitions of resistant hypertension. We all know that American Heart Association, even the European Society of Cardiology has given us new definitions on the resistant hypertension, and both of them essentially are the same. It is defined as above low elevated blood pressure in a patient despite concurrent use of 3 antihypertensive classes. Now, the old definition was any 3 hypertensive classes, but here we have clear guidelines to say that it has to be either a calcitonin blocker, long acting like amlodipine, ACE inhibitor or ARB, and a diuretic. If a person is on these 3 drugs and the blood pressure is not controlled, that is resistant hypertension. Number 2 is the drug should be administered at maximal or maximally tolerated dosage. Now that's very important. Sometimes what we do is to give them a very low dose, which is not the proper way of diagnosis of resistant hypertension. They have to be on a maximum dose. The American definition also includes if the blood pressure is not controlled, despite 4 medication, it is also resistant hypertension, although the European guidelines do not agree to this. So I think there are certain factors which are new in this definition beyond the conventional ways. The first factor is that the blood pressure should be measured and it should be in accordance with the current clinical practice guidelines. Gurpreet, Dr. Wanda gave all of us a very clear enunciation of the current clinical practice guidelines. And the drugs, we already know that there are 3 drugs, minimal or maximal or maximally tolerated dosage. White coat hypertension is not included in this definition. And also, if a person is medication non-adherent, he should not be part of the definition of resistant hypertension. So what's the epidemiology? Now, this is the data from more than 3.2 million patients of hypertension. And it's a compilation of lots of studies over a period of almost 50 years. True resistant hypertension is about 10%. That means 1 in 10 patients of hypertension that we see in a clinic will have resistant hypertension. Now, if we can place it in a perspective, what we'll realize is that every doctor, every clinician sees about 10 to 20 patients a day of hypertension. So at least 1 or 2 patients per day are true resistant hypertension. Apparent resistant hypertension also includes the white coat, the non-adherent, which is 14.7. It is slightly more common among the elderly and very common in patients with chronic kidney disease. So what's happening in India? In India, there are not many studies. There are studies from Colombo, from Karachi in Pakistan. And there are 2 studies from India. One was a nationwide study, 4,000 patients, and what they found was 19.5% prevalence. In our own study at Jaipur, what we did was an evaluation of 3,000 patients of hypertension, and we had about, again, 19% prevalence of resistant hypertension. And remember, these 2 studies from India are basically at the secondary or the tertiary care levels. So in the primary care, the prevalence of resistant hypertension will be slightly low, maybe about 10%, but in the secondary practices, almost 20% or 1 in 5 patients with hypertension will have resistant hypertension, requiring beyond 3 drugs for blood pressure control. What is the prognosis of resistant hypertension? That's very important to realize because everything, ischemic heart disease events, cerebrovascular disease, heart failure, end-stage kidney disease, mortality, and any event almost goes up by 2 to 3 times in patients with resistant hypertension as compared to patients with non-resistant hypertension. So clearly, it's a very important clinical problem. So how do we evaluate that? And we have to have an idea that what are the patient characteristics in resistant hypertension. We all know that it is slightly more common in African Americans and Africans, But in India, that is not the issue. Older age and male sex are again risk factors. If you have comorbidity like obesity, left ventricular hypertrophy, diabetes, albuminuria, chronic kidney disease, high risk score, and sleep apnea, again risk factors. So these are the risk factors. And even these people, we have people with high blood pressure not controlled. We should always suspect resistant hypertension. There are certain physiological aberrations in these people. Vascular disease is quite common. They have impaired endothelial function. They have impaired arterial compliance. There is increased systemic vascular resistance. There is a decreased nocturnal decline in ABPM, lower heart rate variability. The reverse dipping, that means they do not have dipping at night. That means they have reverse. That means there is an increase in blood pressure at night or early morning hours. Again, a very important characteristic. So what do? We need to confirm the treatment resistance. And I've already told you both the AHA and the European guidelines are clear that the blood pressure recommended strategy fails to lower blood pressure less than 140/90. This is resistant hypertension. And ABPM or home blood pressure monitoring is a good method to identify or to confirm the diagnosis of treatment resistance. We already know that how to measure blood pressure, and this is, I think, a very important component because all of us make mistakes in blood pressure measurement. We also realize, and what I tell my patient is that not only us as physicians should know how to measure blood pressure well, we should also educate our patients, our people, how to do blood pressure measurement clearly. Lots of patients come to me, they say blood pressure 180, 170, 110 at home. I ask them, what's the way you measured? So whenever they are feeling discomfort, they'll measure the blood pressure. That is not the way. It has to be a proper process, which is enunciated here. We all know that. And that's how blood pressure should be measured, even in the clinic and also at home. We need to exclude pseudo resistance. That means we need to confirm adherence to antihypertensive therapy. Almost 20 to 30% of our patients are non-adherent. And this is a very important group. And before labeling them that they are having resistant hypertension, we should exclude pseudo resistance. We should also exclude white coat hypertension by doing either ambulatory blood pressure monitoring or multiple home blood pressure monitoring at a fixed time over a period of 12 to 16 hours when the patient is awake. Medication non-adherence is important, and adequate adherence is defined as if more than 80% of medicines are consumed in a month's time. In European studies, at least in the UK, almost 50% of patients are adherent at 12 months, and only about 20% take medications at appropriate dosages. Multiple causes of this is present. However, the clinical assessment is poor, and there are multiple ways how you could measure non-adherence. How do we overcome adherence, or how do we overcome barriers? We need to change the health system level, like we need to improve access to care, we need to improve affordability, convenience, we need to have provider level changes, we need to have better education. That's what we are doing right now. It has to be motivation and cost awareness. Many times, even in rich people, if you give them a very expensive medication, they will take it for 2 months or 3 months and then stop or change to a lower variety of that drug or a different class of drug. So I think we need to be very aware of the costs. We need to change the consumer behaviors with counseling, continuity of care. And I think in India, especially in the rural population, it is very important that the care of hypertension moves away from physicians. It has to be a non-physician healthcare worker. And some of our trials, we have clearly shown that if you have a non-physician health worker in the process of care, the adherence improved and the compliance improves. And for that, we can train existing healthcare workers or a hospital nurse. We also need to overcome treatment inertia. Now, this is a very common problem among all of us physicians. We measure blood pressure in our clinics. Cursorily, we don't educate the patient well. And unless we do that, the person will not be adherent to treatment. And that's very important important thing. The third step in resistant hypertension is assessment for secondary hypertension. Now we all know primary aldosteronism. I'll just tell you about that. But the renal pericardial disease, I think, is emerging as a very important problem. Previously, we used to say that about 90% or 95% are primary hypertension and only about 5% are secondary hypertension. Now that equation has now changed. Now we know that only about 60% are primary hypertension. Almost 40% of our patients have some sort of secondary hypertension, and that includes renal parenchymal hypertension or obstructive sleep apnea, which are the two most common causes of secondary hypertension. And of course, the third cause is drug-induced hypertension. We need to be aware that what a person is taking drugs or not, especially steroids or lots of analgesics, NSAIDs, and all those things. So they are very commonly used drugs, and we need to be very clear that the person is not on these types of drugs. Now, this is an example of primary aldosteronism. What is the prevalence of that? Now, this is a study from 4 American academic centers, just published last week in the Annals of Internal Medicine. What they found was that in patients with resistant hypertension or stage 2 hypertension, hyperaldosteronism is present in about 20% of these people. So clearly, hyperaldosteronism is an important component to be treated, and we have simple drugs for this treatment. The second thing, of course, is sleep apnea. We all know that sleep apnea is an important cause of hypertension. There's a strong link. There's a dose-response relationship between obstructive sleep apnea severity, as indicated by the apnea-hypopnea index, and presence of hypertension. CPAP treatment studies have shown that if you reduce the severity of sleep apnea by using proper devices, the blood pressure decreases. There are lots of symptoms and signs. We all know that. I think snoring is important. Loud or irregular snoring. Daytime sleepiness is a very important component of sleep apnea syndrome. And then you have lots of other factors like non-refreshing sleep, fatigue, nocturnal choking, dry mouth, morning headaches in a person who has high body mass index. Fourthly, we need to assess for target organ damage, and Dr. Warner just told you what are the target organ damages: ocular, cardiac, renal, and peripheral artery disease by various methodologies. The important question is management. How do we manage these people? We all know the importance of lifestyles. I won't go into details of that. Weight management, dietary salt. Just a bit of information, the new information emerging that sodium has an upper limit and a lower limit. If you go very low sodium, it is bad for you, and very high sodium, of course, is bad for you. So there has to be a midline. Alcohol is bad. We need to improve physical activity, and of course, diet and sleep. Again, an important risk factor for resistant hypertension. What are the drug treatment? We all have drug classes. We already know that diuretics, beta blockers, CCBs, ACE, ARBs, and direct renin inhibitors and other drugs. But this is the algorithm that we gave some time ago. It is still valid, and the latest Indian guidelines also stick to these particular algorithms. What are the drug treatment for resistant hypertension? We all know the first line drugs are 3: diuretics, preferably non-thiazides, or if in a severe patient of resistant hypertension, we can also give loop diuretics. We have long-acting calcium channel blockers, and we have ACE inhibitors and ARBs. The fourth line drug, which I think is now coming up as it should gradually be assimilated into the first line drugs, is the mineralocorticoid receptor blockers, which are important. And every patient which you see, don't test for aldosterone, don't test for renin, just start patients on this drug if he does not have evidence of kidney failures, or if we can monitor his potassium well, The mineralocorticoid receptor blockers, MRAs, they are very good drugs as a fourth line drug. And many patients can reduce the dosage of the first three line if you add this fourth line. Then there are fifth line drugs. Some of these are available to us, like the direct renin inhibitors, like beta blockers. We need to prefer vasodilating beta blockers like nebivolol. Alpha blockers are also available. Doxazosin and prazosin. Prazosin is available very well. And then central sympathetic drugs. And beyond that, we have direct vasodilators, and which includes hydralazine and minoxidil, both of which are available to us. Now, these are the AHA recommendation. Now, what they have said is, if a person has resistant hypertension, you need to substitute thiazide with either chlorothalidone or indapamide. We need to add mineralocorticoid receptor antagonists like spironolactone or eplerenone. If the heart rate is high, we can add a beta blocker or a combined alpha beta blocker or clonidine or diltiazem. The fourth step is hydralazine, which we titrate to maximum. And if it is not controlled, we can substitute minoxidil for hydralazine. So there is almost a 5 to 6 variety of drugs a person is on to control his resistant hypertension. The ESC, the European Society guidelines, now recommend a true drug combination or a single pill combination, and that will improve the compliance of the patient. All of our patients are very apprehensive to take multiple pills. So if we combine 2 or 3 molecules in a single pill, so that is new in the European guidelines. And then there are certain new medicines for resistant hypertension, like aldosterone antagonists. We already talked about that, and new ones are in pipeline. SGLT2 inhibition is a new and emerging. We all know the drugs for diabetes, they are also now used for heart failure. And I have a very strong hunch that soon they will be available for treatment of hypertension, especially in obese hypertensives without diabetes, because they do well. They do control blood pressure, and they also reduce the overall cardiovascular risk. And then you have other varieties of drugs which are available. There are certain interventional therapies for resistant hypertension. Now, the first group of therapies were the renal denervation therapies, which came in a very big way about 10 years ago. Simplicity 1 registry and Simplicity 2 showed promise, but the Simplicity 3 trial failed because if you do a sham control group with the control group, with the intervention group, there was no difference. Carotid sinus stimulation is an exciting technique, may be useful, but not practical. So I don't think this is a practical thing to do, and renal denervation therapies are important. We also need to manage secondary causes of resistant hypertension. We all know obstructive sleep apnea, and these are data from the US. Almost 60% of patients have resistant hypertension. And polysomnography is important, and CPAP support. For primary aldosteronism, we already know we can give spironolactones, eplerenone, or adenoma surgery if there is an adenoma. For renal artery stenosis, if we confirm the diagnosis of renal artery stenosis by a CT angiography or MR angiography, we can do renal revascularization, but not apnea in these people. For kidney disease, we need to do clinical management. For drug-induced or heavy alcohol use, we need to have a discontinuation of the agent. And for thyroid disorders, management is important. Just a slide showing the re-emergence of renal denervation therapies. 3 trials published in the last 3 years, spiral hypertension off med and then on med, showing greater reduction in blood pressure if a person is not on medication, or even if a person is on medication, is having resistant hypertension. The new techniques really help. And then the Radiance Hypertension Solo, which was again a trial mainly in patients with resistant hypertension. So friends, my conclusion, resistant hypertension is defined as uncontrolled blood pressure with more than 3 drugs. It is common and very common in secondary and tertiary care levels of hypertension practices. more than 20%, almost 20%. In primary care, about 10%. We need evaluation to confirm diagnosis. The treatment should focus on lifestyle changes, maximal dose pharmacological therapies. We have new drugs, but then we need to have a judicious approach to advocate for CPAP therapies, for sleep apneas, and renal denervation therapies in selected patients. Thank you very much for your attention. Thank you.